Pediatric neurologist and director of the Neuroscience NH SRCC Children's Hospital since 6 years and Jaslok Hospital and Research Center since 21 years, and also attached to Breach Candy and Wadia Hospital as a consultant. She holds advisory position in Forum for Autism, ADHD, International Ketogenic Association, and many, many more. She is a member of the Ethics Committee at Jai Vakil School for Children in Need of Special Care, Sivri, Mumbai, and the Spastic Society of India, Bandra, Mumbai, that is ADAP. I present to you Dr. Anaita Hegde, who will be speaking on pearls of wisdom in pediatric neurology and neuroplasticity. Dr. Anaita Hegde, the stage is yours. Once again, for those who came. Thank you, a big applause. Dr. Anaita Hegde.
Good afternoon, everybody. It's actually humbling to be standing here in front of you for Dr. Kriplani's oration. I always believe that we as specialists and now super specialists are like the artillery or the AI, but I think the general practitioner is the foot soldier who sees more, who actually knows much more, and looks at a patient far more holistically than any of us with our speciality. So I'm going to try and go into a little bit of pediatric neurology, not high-flying stuff, but simple stuff that I thought you should know about because you are the ones who deal with and interact with parents and young children, sometimes much more than us. So why do you need a pediatric neurologist? I'm sure you've heard this very often, and that is that children are not little adults. And why is that? Because our disorders are different. Our presentation is different. Our outcomes are very different. Our doses and metabolism in pediatric age group is even more different. So what am I going to cover today? I'm going to cover neuroplasticity. I'm just going to touch on seizures and epilepsy, just the things I would like to highlight. And I'm going to try and touch upon a few conditions that we should not miss or treatments that we should not miss, and it will be on a case-based approach. So what exactly is neuroplasticity? It is the ability of the brain to change over time throughout the entire lifespan, either due to internal or external stimuli, so nature and nurture. It comes from the Greek word plastiko, which means plastic, which is like a plastic bottle, which you can mold into the shape that you would like to do it. So this is a schematic diagram of the plasticity of happens of the brain. These are the neurons, as you can see in a newborn, 1 month, 9 month, 2 year, and an adult. So what do you notice? That not just the numbers increase, the maximum quantity is at 2 years of age, which is less than what an adult has in his brain, but the circuits which are there are more thick and more solid in the 2 year and the adult brain as against the newborn and the 1 month brain. And this is exactly what happens to our brains as we grow. So neuroplasticity can be divided into two, positive and negative, so adaptive and maladaptive. So yes, we know after brain injury, stroke, hearing, vision, physical damage, we know that the recovery is significant because of plasticity. Cells are damaged, neurons are damaged, but the neurons around the damaged area learn to compensate for the damaged area. New circuits are built and the bridge is covered again. But you have maladaptive ones. Epilepsy and dystonias are one of the maladaptive variants. Why? They start creating so many circuits. So many new neurons are brought out that they start firing at rapid rates, as a result of which you end up with a different set of neurological problems. When does it happen? Maximum within the first few days, hours, months after brain damage. The first 6 months after any brain damage is the most crucial part. So if you want to do rehab and therapy, you have to push for the first 6 months because that's the window period where you can make the change. After that, the graph is much slower. And it also happens throughout life. So it's not just after an insult, and it's not just in childhood, but you and I are still making circuits in our brain, except it takes us a lot more effort and a lot more time. Where does it happen? It usually happens from areas adjoining the damaged area or from the opposite side of the brain, which does the same function. Speech cortex. That's usually how it goes. And what happens is it sometimes strengthens an old circuit at the cost of losing a new circuit, so you do a compensation. So that's what occupation therapy, physiotherapy, what is it that they do? They just reinforce the circuits which are in the brain, or they make new circuits so that you can get the action that you were doing before. Now, this is a very important graph to show you the potential of brain growth. And as you can see, the maximum potential is in the first 1 to 1.5 years of age. The next highest potential is still about 5 to 5.5 years of age. And after that, it's a relative slow progressive increase in potential. A beautiful graph to show a young boy where functional MRI was done at him from 5 to 20. And you can see how this child was tracked, and different parts of the brain show different signal abnormalities. The reds are more motor function, the yellows are sensory cortex, and the blues and greens are emotion, cognition, higher executive function. You can see it moves to different parts of the brain. So different stages of child development, different parts of the brain are being developed at different potentials. After this 20, till roughly what we are, until apoptosis becomes faster, it stays relatively similar. So you can imagine if I damage the brain at any of these ages, the consequences can be significantly different as against if it happened to you and I as an adult. So this is to show you the potential of development which happens in the first 4 years of life. Majority of our senses, numbers comes later, peer social, the blue line, peer social. Symbol comes in the first year of life. We make signs and symbols to a child and they learn to understand. Language starts antenatally, it starts in fetal. Okay, then we have vision, which starts. The first thing a child does is fixes and looks at the parent. So your vision is actually started, which is there. It's first uniocular, then becomes binocular after a few months. Habitual ways of responding, hearing, and emotional control. Look where the bump is in the first 1 to 2 years of life. And that's the time we need to realize the importance of putting in all the input to make the child's life different. You can see the 0 mark. Motor development actually starts antenatally, language starts antenatally. Most of them pick up in the postnatal and they wean off slowly over a period of time. So what is neuroplasticity? Suppose you say, let me teach my child something, or let me learn something. What do you have to do? You have to repeat it again and again and again and again, but you have to do it with passion. You have to arouse the hormones within your system. You get it? So when that passion is aroused and you repeat it again and again, you lay a circuit which from a kacha rasta becomes a pakka rasta, becomes a little gully afterwards, and then becomes a road and then a highway. Once you've made the highway, even if you take down the plug and you take down the stimulus, that circuit is laid and the child will remember those things for a period or for the rest of his life. Okay, so it's repetition, creative of new circuits with mental activity, and then you strengthen it. So this is a lovely graph to show you how often you need to. This is children mugging for their exams. First revision, second revision, third revision, fourth revision. You get it? Why do we do so many revisions? Because with each revision, the percentage of retention increases because you have laid a circuit which is better. What influences plasticity? Sensory and motor input, psychoactive drugs, gonadal hormones, parent relationship, peer relationship, stress, flora, diet, exercise. I'm going to show you a few. Stress. We think stress is really bad for us, but no, a certain degree of stress is good for us. You work best and you perform best the night before your exam or during the exam because of the stress. But we don't want to burn you out. So too much anxiety leads to meltdowns, but little bit leads to lackadaisical lethargy. You need to be in that optimum zone of stress for you to perform at your maximum potential. Exercise. A lovely functional MRI study to show after sitting quiet and after just 20 minutes of walking, you can see the signal changes in the brain which are over there, indicating that you have aroused the brain. So after that, any learning, anything can get enhanced. Love. This is something which was done in an orphanage. Institutional child versus non-institutional child. And you can see the difference in the signals in the brain which are there. Something as simple. Now, these are not drugs to prescribe, and these are not doses to know, or side effects to read and tell a parent. But when you have those few minutes with a young parent, especially first child, who's super anxious, just calm the system by saying all the child needs is the basic stuff which is there: activity, love. You'll come to the other ones, stimulation. Okay, so these are different pictures of stimulation, and this is something like a maths grade, how it improves when a child takes remediation versus no remediation. Meditation is known to help us. So you see the potential to increase your circuits improves significantly if you calm the noise which is happening in the rest of the circuits and focus on only what is being taught. Sleep. If only you can take back this one thing for all your patients. The value of sleep in children is very, very, very important. Okay, so those who cram and mug but don't get sleep, their potential of retention is much lower. And this is the same for all of us who work till wee hours of the night and don't get our sleep. Really, it's not doing us any benefit in the long run. This is the amount of sleep a person needs throughout their life. From 14 to 17 hours at 0 to 3 months, to 7 to 9 hours from 25 or 20 years onwards, including all of us going forward. So this is how we ape. This is what happens when we are just sitting together. You learn by example and you learn by watching. Nutrition. What is the value of nutrition? It's called stunting of growth. What happens? A young, unaffording person does not get nutrition. The circuits of the brain need minerals, vitamins. The neurons need to be lined by these, and that's happening maximum, you realize, in the first 2 years of life. So those are the years where all these vitamins, minerals, and nutrients are needed to line the neurons of the brain to get the best circuit. So if I'm deficient there, even if I get a good education, I'm not going to perform to my best. Then in professional life, I am not able to achieve to my best. And then I have children, and this cycle, or this vicious cycle, which is called the stunted growth or the stunted cycle, happens due to the lack of adequate nutrition in the early years of life. And unfortunately, finances plays a part in it. For that nutrition, for that stimulation, for that love also, you need a parent who's there with you and not working or not out in the fields earning for the family. So unfortunately, getting money later in life does not compensate for what happens to the circuits in brain in the earlier phases of the child's life. So 82% of brain develop happens in the first 3 years of life. But don't get disheartened. We are still learning. All of us are still learning, and you will see that this is if anyone is interested in any of this on neuroplasticity. But you can see the difference. What you learned within minutes at this age, you are going to take that much time to learn at the other age. Okay, so the time taken to learn something is exponential, inversely proportional to what you can learn at different ages. And the sad part is, this came out of a study in Harvard, where governments invest in education and stimulation. And look what we do. We don't invest at all in the early years. Then we invest in school and high school, and then we put the maximum budget for postgraduate and PhDs. The maximum money goes there. By then, what's happened to your brain development? Your potential to think laterally, your potential to imagine things, to grow things that way is totally plateaued, or relatively plateaued. You get it? So if anything, this is the age that we should be spending on to get the maximum potential. So the takeaways on neuroplasticity, it's real. The child's brain grows maximum in the first few years. Multiple facts influence growth, okay? Influence the growth, maturity, and plasticity. Exercise, love, stimulation, hormonal development, a whole host of them, nutrition, finance, etc., which is there. But it's never too late. So even today, if you want to put in effort, all of us can still learn something. You just have to work harder at it. So the next thing I'm going to go through is roughly to give you, this is the spectrum of stuff that I see. Okay, so 19% is still cerebral palsy, developmental disorders, epilepsy, and then I have everything that an adult neurologist would see in a different range, with a relatively bigger percentage of neurodegenerative and neurocutaneous disorders compared to the adult spectrum. So just to touch on few things as far as epilepsy, A seizure or a convulsion is an acute clinical change of abnormal neuronal discharge. We tend to use the terms a little loosely. A seizure is the event. A convulsion or a seizure is the event. And epilepsy is a tendency to have seizures where you should have had at least 2 or more of unprovoked events for you to be called epileptic. It may say you're splitting hairs and it's semantics, but at the end of the day, it changes the child's life. If you say you had a seizure or you say you're epileptic, the way you and I look at him and the rest of the world looks at that child is very different. And most of the seizures children get are acute symptomatic situation related where they're due to either a fever or a hypoglycemia or hyponatremia, etc. But then epilepsy is when it happens without provocation or without anything. So how would you try to counsel? And this, when it's acute symptomatic, what is it? It's fever, headache, head injury, hypoglycemia, electrolyte, infection, stroke, the common stuff. What are the chances of you getting seizures again? 3 to 10%. The general population incidence of epilepsy, 3%. If you've had one of the provoking factors, you are like a normal population, only 3% chance of having a seizure again. If you have epilepsy, you are not precipitated by these things. You are precipitated by lack of sleep. You are precipitated by excess emotions, by stress, by fatigue, by infections or a family history, and your incidence of having repeated seizures is 50 to 70%. So you see the difference in the two things. The stimuli are different, and the chances of getting repeated events are different. So I always implore everybody that if you ever have a child or a patient of anything and you are not convinced it's the seizure, the first question when someone tells you something is you ask yourself, is this a seizure? There are many mimics which come, and that's a topic on its own. But if you are even in slightest doubt, do not treat. Do not label. If it's epilepsy, it will invariably come back again within 2 to 4 months or down the line. Then you've got 2 seizures. Then you are justified inside to put a child on 2 to 4 years of an anti-epileptic medication where you know what's happening to the brain in those days and years of your life. This is not an age you want to add a medicine unless it is absolutely essential for the child's progress and development. So it's better to err on the side of being saying that it's not an epilepsy. Do the EEG, do what you need, we'll give you that what you need to do, but do not start medication unless you are absolutely convinced that you've had 2 events which warrant treatment. Okay, so in febrile seizures, the take-home message from febrile is only one: no role for medication. There is proof today that no intermittent prophylaxis, no intermittent antipyretic also works. We still give antipyretic medication. Many of us give clobazam for 2 or 3 days as that, but evidence-based medicine does not support it. Okay, but febrile seizures, 10% of the population happens, it will go down, it doesn't have an effect. Only 10% of those children will go on to long-term pictures. So if you have the first seizure, the only investigation you need to do is an EEG. And I again request if you can do an EEG with a pediatric neurologist or someone who's comfortable with pediatric EEGs. Why is that so? You saw the graph of growth. The EEG that an adult person sees is here. The EEG that a pediatric person, we see what it is, the age of the child. The whole development of the EEG changes with age. So the EEG is different at 3 months, 1 year, 3 years, 8 years, 10 years, and roughly by 12 to 14 years, you've got an adult EEG on your graph. So interpreting of those EEGs and the epilepsies is very different. So MRI, neuro, labs, etc. is ideally not recommended, only an EEG to help you, to guide you going further. And do I treat after the first seizure? Preferably not. I've tried to explain to you why. There is adequate evidence to say that the long-term outcome, if you start after the second seizure versus the first seizure, is equal. So you are not putting the patient into any long-term danger if you don't treat at the first seizure. So these are the drugs, and as you all know, the number of drugs today is just exponentially increasing. Today, cannabidiol is the new drug which has come out about a week ago. We have 4 pharma companies who have come out with it. Very expensive at start, but competitively will decrease. And when you choose the correct drug, remember that the tolerability is more important than the effectiveness. I'll give you that slide again. I'm happy to give you the whole presentation if you need, so I don't think you need the slides. But the tolerability is more important, because there was a lovely study to show that all drugs when you start it are almost equally effective. So how do you choose the drug? You choose it according to the tolerability. So if the child across is obese, I'm never going to put valproate. If the child is skinny and mom is obsessed with food, I'm never going to put topiramate, because it makes you lose your appetite. You get it? So you got to know the side effects of your drug better than the effects of your drug, so that you choose your drug according to the tolerability. And these are the drugs that we routinely use for most of the time. If it's generalized, valproic acid till date, though it's an old drug, is still the drug of choice. Levatracetam or brivaracetam, lamotrigine, topiramate. Absent seizure, valproate is still number one, ethosuximide and clobazam. And focal seizures, carbamazepine, oxcarb, lamotrigine, levatracetam, zonisamide, valproate, and phenytoin. But at the end of the day, as a physician, you have a sixth sense, and you have a comfort with the drugs that you choose, and you have seen side effects, so you know what to look for in certain patients. So go with what your gut and what you're comfortable with. But the one thing you must do in every child, even after the first seizure, even if you do not put any medication, which I hope you will not do after the first seizure, this is something you must teach every patient who has a potential for epilepsy. Intranasal midazolam, it's available now in 2 or 3 companies. You have 2 strengths, 0.5 and 1.25, and you have to put it into the nostril only after 3 minutes of the seizure. We do not do it as soon as the seizure starts. You wait for 3 minutes. If it doesn't stop, why? Because if a seizure doesn't stop by 5 minutes, the chance of going into status increases. We definitely do not want status, and we definitely do not want long seizures. Small events do not damage the brain. Long events, yes, you run the risk of permanent CNS damage, which is something I cannot afford to have. So anything longer than 3 minutes, you tell the parent, lie the child down, prop the head a little bit, put it into the nostril, you do fuss, fuss, fuss over here, fuss, fuss, fuss on that, you wait. 90% will get aborted. If you fall in that 10%, unfortunately, you can do it a second time after another 3 minutes. But you cannot do it a third time, because you run the risk of respiratory depression, so you have to refer them to a hospital, or they need to get to a hospital there. But this is essential. So I have a little page with a diagram which I just give out to everyone, and I explain it to them every time. So how do we go? We do monotherapy. If it doesn't work, we try another monotherapy. We don't add 2. We take off the first and put a second. If it doesn't work, we try a third. If third monotherapy doesn't work, we start combination therapy. If 2 combinations in trial don't work, we go to a combination of 3, and then you have ketogenic, surgery, and VNS. But let me show you. The chance of monotherapy working is 60%. The chance of combination of 2 drugs is an additional 10 to 15%. The chance of 3 drugs working is 1 to 2%. You get it? So just loading them with medicines is not the solution. There is a new trend I have seen, that instead of starting with 1 drug, everyone is starting with 2 drugs together. I don't know whether it's you just want to cut it out immediately, but somewhere that little time to explain, I'm trying to highlight the developing brain. And I'm trying to highlight the less medicines. If any of you takes a topiramate or takes a valproate, see what it does to you. It's not a small thing. So you don't want to do it unless it's essential. And if you have failed any 2 drugs, you are on the chart for intractable epilepsy, refer early so that we can do something earlier and protect the brain from having long-term damage. So a few cases to highlight: a young child of a 3rd-degree consanguineous, regression after an acute infection, gait abnormality, irritable, language, everything was regressed, and otherwise she was slightly conscious but irritable, and her examination was relatively normal. This was her MRI with bilateral basal ganglia involvement, and her spectroscopy didn't give me anything but a mild lactate peak. So, as everyone would think, ADEM, that was the first thing that ran with the radiologist gave, could this be an ADEM or could this be a mitochondrial? We covered with both, the mitochondrial as well as the ADEM. And 3 days later, she was up and about and running, and we all thought, oh, it was the steroid that did the drug, until the genetic report came. And you can see 6 months later, the lesions are almost gone on her MRI, and her genetic report came thiamine biotin deficiency. All that made the difference was that thiamine that I gave her. So there are few vitamin-related conditions which can be life-changing for children, which I thought I need to highlight so that we don't miss them. You give it and it doesn't make a difference, okay, we go down the regular path. But if it makes a difference, it can change that child's life, because the longer you keep them in that state of metabolic disarray, the cognition and the development obviously exponentially goes down. So this is another one who had normal birth history, and on day 2 of life started having seizures, multiple drugs given, a trial of pyridoxine. After multiple AEDs, pyridoxine was given, dramatic improvement, it improved in her milestones. Whenever the parents stopped the pyridoxine, the seizures came back. So that was her EEG when she was without the pyridoxine, and that was literally 1 week later. That is a burst suppression EEG. That's like when you're in hypoxic ischemic damage, the worst EEG you can ever get in a patient. Like the brain is not functioning at that stage. And look at the EEG 1 week later, just with a trial of pyridoxine. So that was the genetics that came out, and this was pyridoxine dependent. Lifelong, this child will take pyridoxine and should be absolutely fine with a normal life and development for the rest of his life. So what are the vitamin deficiencies or the vitamins? Pyridoxine is one of them. Biotin is another one. For biotin deficiency and biotin thiamine responsive basal ganglia. So I've shown you 2 examples out of these. So the take home here is if you get neonatal or early infantile seizures or a regression, if you have skin lesions, you're thinking biotin. If your EEG is showing abnormality, usually all of them will show it. If there's a family history or sibling losses or a normal birth history, think other than cerebral palsy. Everyone thinks that's the first thing that comes to your mind. If you have a normal birth history or a positive family history or sibling losses or a regression of what the child achieved 2 days before, you are not looking at cerebral palsy. You need to start looking somewhere else. And if you don't know what it is, and you have the genetic takes a month for the report to come back and $30,000. So it takes time to organize all that. Start with biotin, B6 and thiamine. At least you have covered the treatable conditions that you do not want to miss, so that the child has a better chance for a better future. Day 28, child came back, came with seizures starting at day 10 of life. You have multiple seizures which are there. This is the young child. I don't know if it comes, yes. Was tried with levetiracetam, phenytoin, no improvement, came to us with biotin, pyridoxine, we gave it, no benefit. You can see the EEG out here is having a run of seizures. The child is actually convulsing at the time of this EEG. And given this not responding to anything, we tried phenytoin. Now, phenytoin is not the drug of choice in neonatal seizures. But we tried phenytoin, why? Because we are thinking genetic epilepsies. So this is where we have reached today. Genetics has changed the way we see our stuff. Okay, thinking of an SCN, I put the phenytoin, the seizure stopped, but that 20 days that the child was not under seizure control, though the seizures have stopped for life now, the developmental delay this child has is significant because of the epileptic encephalopathy. So sodium channel drugs, due to certain sodium channel genes, and what are your sodium channel drugs? Phenytoin, carbamazepine, oxcarbon, lamotrigine, have an opposite reaction. So if they come less than 3 months of age, you should try them. If the seizures come greater than 3 months of age, you should avoid them. So it's very difficult for you all in your everyday practice. So if you have intractable seizures, do not waste time. Refer to a specialist who can help you identify which is the drug to put this child on. And this is what we call precision medicine. So these are the genes and these are the different things that if you give them, and one of them is quinidine, one of them is everolimus, one of them is a ketogenic diet, and you can change their life forever. But the earlier you start the correct drug, the better the long-term picture of the child. So seizure control and developmental epilepsies can be life-changing with the correct drug. Another condition you cannot afford to miss is tuberous sclerosis. Look for the lesions if a child comes to you. If the child has lesions, immediately what we do today is we do an EEG as soon as we see the lesions. We do not wait for seizures. Why? Because if you can start vigabatrin before the seizures start, you can save their cognition. If you start vigabatrin after the seizures start, they are delayed development for the rest of their life. So this is a lovely study which came out called the EpiStop study. They monitored EEGs of children from the time they were born of those who had lesions on them or family history of tuberous sclerosis. The minute they saw a change on the EEG, they started medicine and they saved their cognition. They may get seizures afterwards, but their cognition was saved. Whereas those who got the seizures and then put on the medicine, so honestly, this is the only indication for prophylactic anti-seizure medicine. And vigabatrin is the only anti-epileptic medicine. Otherwise, all our meds are anti-seizure medicine. They do not take away the epilepsy. They suppress the seizures. They do not take it away, whereas vigabatrin, because it works on the gene through the mTOR pathway, it actually changes the genetic infrastructure and you don't get seizures. Okay, so then I'll just show this set and then we are done. So the first child, this was a young girl post-COVID. She came with this abnormal gait. She had stopped going to school. Everything else was normal. The important thing is that her B12 was very low. We put her on B12, she responded beautifully, she was back in school with a lot of psychological counseling as well. And this is a 20-year-old child who had regression of milestones, had lost his sister to the same disorder, was wheelchair bound when he came to me, and if you see his MRI with severe cortical atrophy, we did his B12 and homocysteine and we picked up that homocysteine was very high. We put him on B12 and homocysteine and betaine and his MRI actually improved after 20 years and the kid walked into the clinic the other day. Now someone from a wheelchair to come up, trust me, in neurology you don't see miracles. Very, very few miracles do you ever see. So this is really something and it's as simple as B12. So we have a dictum that we do not miss a B12 or a homocysteine. Any child with a neurological or adult for that matter with neurological problems, you should consider doing a B12 and a homocysteine to see that you haven't missed a treatable cause. And these were just 3 cases of cerebral palsy which were treated as cerebral palsy. Each of them was different. One was a genetic disorder, one was atlantoaxial subluxation, one was congenital thyroidism, and eventually there is adequate proof to show that 10 to 15% of cerebral palsies treated when they did genetics, they found a gene abnormality. So go into the history and see that you're not missing one of those red flags to tell you this is not CP. And you can see 10 years, 14 years, and 15 years. They've been treated as CP for 15 years before you actually pick up the real diagnosis on them. So in conclusion, neuroplasticity is real. And the time to focus is the first few years of life. Early developmental regression, seizures, abnormal movements, remember the essential vitamin supplements till you get a diagnosis. So treat until proved otherwise. B12 and homocysteine should be part of all routine neurology, biochemistry. Early reference, understanding genetic function leads to early corrective choice of medication and thus leads to protection of neurodevelopmental delay. Tuberous sclerosis, early diagnosis, early reference and treatment with vigabatrin can actually change the long-term picture. And cerebral palsy, everyone is not plain CP. When they come inside, get those few red flags and if you have it, refer and see whether we can make a difference. Thank you.
Thank you, Dr. Anaita Hegde, for an excellent, informative and interesting talk. I call upon our President, Dr. Preeti Bhargav, to please come and felicitate Dr. Anaita Hegde. Excellent. A big applause. I call upon this stage Dr. Ashok Kriplani, sir. Just a moment, Dr. Ashok Kriplani will also join. Thank you, sir. A big applause. Thank you, Dr. Ashok Kriplani, Dr. Preeti Bhargav.